bone and joint infection, that's to say osteomyelitis and septic arthritis. What is osteomyelitis? The word osteomyelitis is derived from osteum, which means bone, myelo, marrow. Itis means inflammation, so it is an inflammatory process involving the bone and the bone marrow. How can organism reach a bone? Either hematogenous, which is the most common type, or non-hematogenous, that's to say after open fracture, after operation, or direct spread from adjacent infection, such as if you got a chronic leg ulcer over the tibia, we can get osteomyelitis of the tibia. We can classify also osteomyelitis according to the host response to infection as either biogenic or non-biogenic. Now we are going to talk about the most common type of osteomyelitis, which is acute hematogenous osteomyelitis. The most causative organism, the most common causative organism is Staph aureus. However, other organisms can contribute to this infection. It is commonly seen in boys between 3 and 10 years due to rich epithelial blood supply and the immature immune system. And if you got an adult with acute hematogenous osteomyelitis, you should search for the cause of that. He may be an elderly patient debilitated, or got diabetes mellitus, or in certain drugs which decrease the immunity system. The source of infection may be not evident, but we always search for upper respiratory tract infection, tonsillitis, or boils. Trauma is one of the predisposing factors. Presence of also of septic focus or lower general resistance. Any bone can be affected, especially long bones of the lower limb around the knee. So any patient come to, any child or boy come to complaining of pain in the distal end of the tibia or in the upper end of the tibia or in the distal end of the femur and got fever or something like that, you should suspect acute hematogenous osteomyelitis. Why metaphysis is the commonest site? We know that we got in the bones of the what we call epiphysis, metaphysis, and diaphysis. So why metaphysis is the commonest area for initial lesion? Because it is immature bone, because of the vascular arrangement in sinusoidal fashions, which makes the bacteria, the blood slow down and the bacteria settle in this area. And the other thing that metaphysis is more liable to trauma. If you can see this X-ray, this is what you call bone inside the bone. The inside here is the bone inside the bone. Here is the involucrum, is the sequestrum, and the outer side is the involucrum. Again, the inside is the sequestrum, outside is involucrum. So are the local pathological stage. We have stages of suppuration, secretion, and involucrum formation. How suppuration occur? Pus accumulate inside the form rapidly and delays the local intramedullary abrasion, and then infection is spread either to the surface, forming what we call supraortistial abscess, or down to the medullary canal, or rarely through the epiphysis, and they cause what we call septic epiphysitis. But this is common in infants, rare in children, and may occur in adult. So what is the stage of sequestration? As periosteum is raised by the pus, the outer layer of the cortex is denuded from its blood supply, leading to necrosis of superficial part of the bone. Okay, intramedullary spread of infection may denude the inner cortex, so that we have the outer cortex affected and the inner cortex affected. And this explains why some cases we have a lot. We know that the initial site, as we mentioned before, occur at the metastasis. But why some cases, when we see some cases on X-ray, we find that the whole bone is affected? That is because the nutrient artery or its branches may be thrombosed and the big sequestra form. So after the detached periosteum, you know that the bone try to respond. So sequestration is a dead bone, a closed bone. So now the bone is dead. So what the bone can do? So the periosteum try to produce another bone, new periosteal bone formation. And this new bone formation may contain holes. Okay, this hole is called cloacae. And the involucrum itself is the new periosteal bone formation. This is the different patterns of acute hematological osteomyelitis in different age group. So, how to diagnose this case? Infant usually predominates, okay, or children and infant always numerate. We can see some cases in the ICU because of septic epiphysitis of the hip. But children and infants predominate with equal sex distribution. We always get this patient, a boy, complain of rapid onset of fever and pain, and he is not using his lamp. Okay. So generally we got fever, tachycardia, and manifestation of septicemia. We have severe localized tenderness over the inflamed part and other manifestation of inflammation. We may have effusion, sympathetic effusion in the nearby joint. When we do blood investigation, we will get leukocytosis, elevated CR, positive C-reactive protein. Blood culture may be positive in 50% of cases. And bone aspiration is the most certain way to confirm the diagnosis. We always aspirate from the subperiosteal abscess or from effusion of the adjacent joint. And the aspirate is sent for cultural sensitivity, cytological examination for the pus cells. During the first 2 to 3 weeks, X-ray is normal. Sometimes you can detect soft tissue swelling. By the second week, the canal become affected and the bone become rarefied. By the third week, we will have new periosteal new bone formation. MRI, bone scan, and ultrasound are not routine investigation. Differential diagnoses of acute hematological osteomyelitis include rheumatic arthritis, acute septic arthritis, and cellulitis. Please be careful as regard any boy or girl come to you with pain around the joint and swelling around the joint and fever. You may suspect this patient got rheumatic fever or rheumatic arthritis. Please try to differentiate between both of them, because some patient got corticosteroid and there is actually acute hematological osteomyelitis, so you will lead to flaring of infection. So rheumatic arthritis is polyarticular, fleeting, and you will get other stigmata of the disease. Acute septic arthritis, sometimes because of when you got acute hematological osteomyelitis, we got what we call sympathetic effusion of the joint, but most commonly it is just sympathetic effusion. It is not associated septic arthritis of the nearby joint. So try to find where is the maximum tenderness. Is it over the bone or over the joint? And also in acute hematological osteomyelitis, movement is painful but can be done, but in acute septic arthritis all movements are painful and limits. How to differentiate between cellulitis and acute hematogenous osteomyelitis? When the bone is infective, when you if you get for example osteomyelitis of the tibia, so when you try to percuss the bone away from the site of affection, you will find all the bone is tender. Okay, and this is how to differentiate between cellulitis and acute hematogenous osteomyelitis. Another important differential diagnosis is Ewing tumor. Ewing tumor, the lesion is diaphyseal. We mentioned before that the lesion in acute hematogenous osteomyelitis is metaphyseal, but in Ewing tumor it is diaphyseal, and you can find in the X-ray the other stigmata of Ewing tumor like onion peel appearance. Treatment should be early. Bed rest, splint, maintenance of nutrition and fluid. Give antibiotic initially. Intravenous broad spectrum antibiotic is given. And when you know by culture from the aspiration what is the effective organism, you can give then the effective antibiotic. If methicillin resistant Staph aureus appear, you should give vancomycin as antibiotic of choice. For how long we give antibiotic? We will give for about intravenous for about 1 week or up to 2 weeks, and then followed by oral antibiotic for another 6 weeks. Is there any rule of surgery? Yes. If we didn't get improvement within the first 3 days of treatment with antibiotic, you should do surgical drainage. Okay? And the indication for surgery: clinical diagnosis of abscess formation, failure of improvement within 3 days in spite of intravenous antibiotic, and the presence of signs of acute osteomyelitis in severely ill child, toxemia. You can do drainage of the subarachnoid abscess and or bone draining. What is the complication of acute osteomyelitis? We can have chronic osteomyelitis, septic arthritis, pathological fracture, edema, gross infection, and deep venous thrombosis. Now we finish the acute hematogenous osteomyelitis. What's about subacute and chronic? There is a mild form of osteomyelitis when the organism is less virulent or the patient has good resistance, which we call Brod's abscess. It occurs in the metaphysis of the long bone, like in this case in the distal tibia, and you will find just pain and localized tenderness as we see here. You see a small oval cavity surrounded by dense sclerosis. Sometimes one of the differential diagnoses is osteoid osteoma. For this cavity, we just deroof it and curate it thoroughly and put a bone graft. Okay, what about chronic osteomyelitis as a sequelae to acute osteomyelitis? Why acute osteomyelitis become chronic? Because of persistence of bone cavity, bacteria, sequestrum, or sinus. How to diagnose? We got a history of acute osteomyelitis, and there is pain and discharging sinus, and sometimes the sinus itself produce small sequestra or small dead bone. The X-ray shows that the bone is thickened and tender. X-ray shows that the bone is thickened. We will have sclerosis surrounding the bone cavity. As we mentioned before, you can see what we call bone inside the bone. This is the bone inside and this is outside. This is sequestrum, this is involucrum. Complication of chronic osteomyelitis: pathological fracture, irregular growth, squamous cell carcinoma sometimes occur, and amyloid disease is rare. Does antibiotic has any role for a chronic osteomyelitis? We mentioned in acute osteomyelitis that in acute osteomyelitis we should give first antibiotic, but here antibiotics are of little value because it cannot reach the bacteria hidden in the vascular tissue and sequestra. But sometimes we use it in acute exacerbation or when we are going to do operative drainage of the patient. Sometimes we put what we call antibiotic locally, put beads of antibiotic impregnated polymethyl methacrylate in the surgical defect. So how can I treat chronic osteomyelitis? Radical debridement and closure of dead space. Radical debridement consists of resection of the scarred and infected bone, including the sinus tract. I should include the sinus tract during my resection. Suturization of the bone cavity, that's to say de-roofing of the bone, and sequestrectomy, that's to say removal of the sequestra. So we will find that we got a dead space or a defect. How can I deal with this defect? We have soft tissue reconstruction alone or combined with bone reconstruction. Soft tissue reconstruction can be done with local muscle flap or free vascularized muscle flap or free mycocutaneous flap. Bone reconstruction, we can put, if we have a bone defect less than 4 cm, we can put a cancellous bone graft. If more than centimeter bone defect, we can put a vascularized bone graft. Sometimes we do what we call bypass graft, that's to say cross union between tibia and fibula. And in special situation, we do use Ilizarov technique. In certain part like fibula, if we got middle third or upper third of the fibula affected of chronic osteomyelitis, we can remove it, so excision of certain part. Amputation is rarely done nowadays and indicated in carcinoma of the sinus, amyloid disease, mutilated limb, but however, it is very rare to do amputation in case of chronic osteomyelitis. There is a special type of chronic osteomyelitis, we call it Gary type or sclerosing, chronic sclerosing type. It is a non-suburative type of osteomyelitis affecting shaft of the long bones and jaw. We will have diffuse thickening of the bone with obliteration, complete obliteration of the medullary canal. Treatment, we excise abnormal area and expose surface curated thoroughly, plus or minus bone graft and bone transport by Ilizarov. This is common, which is post-traumatic infection. Open fracture may be infected. This is the usual cause of osteomyelitis in adult, okay? And is a consequence of this infection that the fracture itself will not be healed. How can we prophylactic, how can we avoid that? By debridement, good debridement of open fracture, stabilization of the fracture, and antibiotic and early closure if exposed bone surface. But if we got an established infection, so we should give the patient antibiotic, regular wound dressing, removal of loose implant, application of external fixation, and if we got stable implants, please don't remove it, leave it until union of the fracture. Okay. Now after we finish bone infection, which is acute osteomyelitis, we said that we got acute hematogenous or subacute osteomyelitis or chronic osteomyelitis or post-operative infection. We will now discuss what we call septic arthritis or pyogenic infection of bone. In children, the host of organism, commonest host of organism is Staph aureus. In adult, gonorrhea or staph. Route of infection, hematogenous, direct extension from adjacent source of infection, direct implantation from without, like open injury, postoperative infection, intra-articular injection. Any joint can be affected, but in children, the most common site is the hip. This is in neonates because of when they got a lot of antibiotic from the area, a lot of intravenous injection of antibiotics. Sometimes because they are immunocompromised, we got septic hip joint in the neonates. What the local changes which occur? The synovial membrane itself, The first, we said that in acute osteomyelitis, the organism settle in the metaphysis. Here, the organism settle in the synovial membrane and they produce synovites. Okay, and then the articular surface become affected by what we call chondrolysis. That's to say, the articular cartilage itself become dissoluted by either the digestive action of proteolytic enzymes or direct action of bacterial toxins, or by what we call excessive plasmin. The subchondral marrow space become filled with pus, and a ligament become shortened, become softened and stretched. Capsule may rupture, lead to an abscess. And finally, we may get what we call pathological dislocation, and this dislocation may be due to muscle spasm, increased interarticular pressure, ligament laxity, and destruction of joint space, of joint surface. What's complication of septic arthritis? Chronicity, pathological dislocation, and pyemia. What is the course, or what is the natural history of infection? It depends on the virulence of the organism, the effective of treatment, and when we use that treatment. Sometimes we got recovery of the joint mobility if we begin the treatment early before the damage of the articular cartilage and when we use the proper antibiotic. But ankylosis will be the result if the articular cartilage is damaged beyond repair. Septic arthritis can occur at all age, but it predicts childhood and is frequent in male. We got sudden onset of fever, toxemia, and the patient cannot use his limb. We got swelling of the joint, deformity, pain, tenderness, local signs of inflammation, limitation of all movement, joint movement, and muscle is. X-ray, early, it is normal, but we can have soft tissue swelling and widening of the joint space, but after 1 month we will have rarefaction of bone ends, and in advanced cases we got diminished joint space, irregular joint surfaces, and subchondral sclerosis. We will have lab increased ESR and leukocytosis, and the aspiration of joint for diagnosis. We sense aspirate for cytological examination for detection of pus, culture, and sensitivity. Differential diagnosis, acute osteomyelitis and rheumatic arthritis, as we mentioned in differential diagnosis of acute hematogenous osteomyelitis. But here we can add hemoarthrosis, okay, and TB arthritis. In hemoarthrosis, there is a history of trauma, and general manifestation are not so severe, and when we aspirate, we will reveal blood. In TB arthritis, the onset is insidious and is chronic, and a cold abscess may present, muscle atrophy is marked, and X-ray show rarefaction of bone end rather than sclerosis, which was mentioned in pyogenic infection. How can I treat septic arthritis of joint? Bed rest, antibiotic, maintenance of nutrition and fluid balance, put the limb in the best position of function by splint to relieve the muscle spasm and pain, and then do drainage. Drainage either through open arthrotomy or repeated needle aspiration and irrigation. This is in superficial joints and in children, or arthroscopy. Thank you.